thought process, partly because the patient as you see them is jaundice or has pain. So then you have to make a call based on the clinical picture. And so logistics come into play, right? So if you get an MRCP, that's a delay. If you're in an inpatient setting, at least in the US, getting an MRCP takes a day at least, then the interpretation from the radiologist. Whereas if you have the setup, you can do the EUS, ERCP all at once. So it depends.
There's actually a study, I think, which we were discussing regarding the gallstone hepatitis thing, that if you have, they made a pathway in which there is no MRCP actually. If there is low or intermediate suspicion of a CVD stone, you directly go for surgery and then do an intraoperative colectomy. And the reason for that is because of the delay of the MRCP. Even there it takes a day for the delay, that keeps the operative. So at our hospital, we're trying to encourage the surgeons that they can just do it in the US. They are doing it very cheaply as well. I think it's just 30,000 rupees. But they're still not entirely doing it.
So this last case, we did not know patient had a stone. So we were planning actually, because bilirubin was the only which was high, we're planning like if we don't see anything in the bile duct or no obstruction, we'll do a liver biopsy. But when you see an intrahepatic ductal dilation that prominent, there has to be obstruction. And so that was very clear on that, and there's a huge stone.
So ERCP today? Or?
I don't know. Kab karni hai ERCP?
ERCP, I think,
आज कर रहे हैं, कल कर रहे हैं.
Is he with no symptoms? Pain nahi hai?
No, just jaundice.
And you know the rest of the
Next patient is treated without Next patient, sir. वो sedate हो चुका है. I'm just gonna tell you वो transpired normally Thursday, sir. ऐसी कोई imaging वैसे है नहीं अभी currently. So this is a 6-year-old male patient with abdominal pain and vomiting. He's hypertensive and diabetic. Basically, the patient was referred to us with deranged LFTs. His total bilirubin at the time was 11.6. So an ultrasound was done that showed dilated CP and dilated intrahepatic ducts and stones. So an ERCP was done right here in Seattle, and that showed multiple filling defects and a distal end tapering. Some of the stones could be removed, but there was some holdup because of the tapering, so an evaluation was done with a CT scan. Ultimately, patient also gave a history of 2-3 kg weight loss. So the CT scan itself had shown that there's a soft tissue thickening in the ampullary region, measuring 1.8 by 1.2 centimeters. And there are some lymph nodes around the area as well. So this is the next case that we have. The patient is sedated, so Dr. Mustafa can join us.
Ampullary mass basically.
Yeah.
with stones in the body.
With the
With
stones.
stones. And a stent has been placed.
Does biopsy of the ampullary lesion affect your removal afterwards?
Of the ampulla? No.
No. So
But
it's
if you do a sphincterotomy, then yes. Yeah. So that could be challenging. Because then you can't grab the whole ampulla. It's hard to grab the whole ampulla with a snare. Ideally, whenever you're doing an ampullary lesion, it should be in one piece. But if it's a laterally spreading tumor, it's not going to be one piece. But ampullary area and the tissue around that should be in one piece.
So if somebody in the periphery or in a smaller hospital is doing, let's say, an ERCP, attempted ERCP for a patient, and they found an ampullary growth, then ideally they should just put a stent in.
Put the stent
and
in
do a
and not do
biopsy.
it. Yeah.
Don't even do biopsy.
Yes. No, biopsy, I think it's a good idea to do.
Okay.
Actually, you should not do an ampullectomy without a biopsy.
Okay.
Okay. So you need to have some so we like because if they don't do it, and we might do it, because ampulectomy patient can develop a pancreatitis, bleeding, obviously this perforation. So you need to make sure that you're doing it.
do papillotomy that time.
Don't do it because that's going to make it really difficult to remove the ampullary lesion. So just put a stent in, just do a biopsy, and
At times it's difficult to get the stent across in the papillary area.
usually it's easy when they have ampullary lesion. Yeah. So unless it's all tumor and all that stuff, in that case it's not going to be acceptable anyway if it's ulcerated mass. Ulcerated mass there is already invaded. So that's no point trying to attempt endoscopic resection. लेकिन बाकी जिसमें it's a polyp, many times it's much easy to get the stent in there and just put the stent in there, just do a very two small biopsies. I usually in those cases I use a pediatric biopsy process, not use too much for a bigger biopsy, just a small biopsy on from the surface, not too much deep in there, and then just wait for biopsy if it's adenoma, then you just